The concept of one size fits all is really, we can apply it to many things outside ophthalmology. People do different things, they have different jobs, they have different requirements for distance vision, intermediate near vision. We're in Hong Kong now, it's a very urban setting like Singapore is and stuff. We don't have any rural areas or basically areas of farms where it's very dark at nighttime. So people's real requirements are different. So that's why we have to always try to tailor our lenses to the patient's requirement. And you know, we have fantastic lenses now, better than we had like 10, 15 years ago. So we have the ability as doctors to basically do this rather than sit to the old sort of fashioned way of hoping one size will fit all. And then if you're not happy with it, you know, this is the best that we can basically do.
I usually categorize personally in two types of people. People who really want to be spectacle independent. Then I usually go in the trifocality area. All those people who have a lot to work on, still drive at night, are afraid of halos optical symptoms, then I go in EDOF type lenses, the modern type of lenses, the Aconex or the non-diffractive EDOF lenses.
I think there's two different ways of working with blended vision. One approach is to work with a monovision approach, targeting one eye on 0 and targeting the other eye on -1.5 with the comfort IOL. And the second option is to use a comfort IOL in combination with an MF30, with binocular emmetropia. That's actually a very easy way to start, because both eyes are targeted on emmetropia, so the patient will always have good binocular distance vision.
There are many choices. For me personally, I usually have investigated on these IOLs and I know the outcome, and that's the reason why I implant them in my patients. So there is a full range and we have to understand which IOL to which patient, sometimes not so easy. But the best thing is that you know the outcome of your IOL which you implant.
One of the sort of black boxes for any biometrical error is basically the lens position inside the bag itself. By taking that away, by tipping it to the anterior capsule, effectively we know exactly the effective lens position of that intraocular lens, which means our biometry can be basically more accurate, which means our refractive error can basically be more accurate as well. And what it's doing is elevating your cataract surgery from a therapeutic procedure to a refractive procedure. And once you start thinking about things from a refractive surgeon point of view itself, you need to have much more tighter outcomes and more predictable outcomes. And by doing capsular fixation, it allows you to basically do that.
One reason for us to use Teleon is because they have two platforms and they have all their optical designs available on those two platforms. Also, it gives us the possibility to choose different optical designs to individualize our patient care and still using the same platform, the same material, the same injectors. Individualized patient care does not mean that you reduce your efficiency. Actually, it just means you can become more efficient, because with caring more individual, you get better outcomes. So you have to standardize your workflow to be efficient. The only thing we do is we pre-group those IOLs and put them into a language that is understandable for patients. So we don't talk about EDOF, monofocal plus, multifocal diffractive. We talk about standard, economy, light, business, and first-class treatment of your eyes with IOLs.